Because of COVID-19 and the restrictions in place at the moment, we've put together a video for you of the professions involved in the emergency pathway at the Norfolk and Norwich University Hospital. The video will take you through surgical AEC, into theatres and back onto the emergency assessment unit. This video is to give you insight into the different professions involved in our unit, and we hope to inspire you into a career in healthcare.
As a Band 6 nurse, we coordinate the unit on EAUS, so that means lots of phone calls between different departments, different wards, organising patients coming in, organising patients going out, relatives, other staff members, lots of talking between departments and other people. Yeah, I think we see people on the worst days of their life. They come in here and they come in here unexpectedly. They don't expect to come. Always want to be a nurse. From a child, always wanted to be a nurse. I never even considered anything else. My whole aim at school was to become a nurse, and that's what I did. Nurses aren't just bedside nurses anymore. There's all sorts of things you can get into. You can actually become a nurse consultant nowadays, which was unheard of when I started. So the opportunities are endless if you want to be a nurse nowadays, and it is very rewarding.
Surgical AEC is to provide care for ambulatory patients, so there are patients that can walk in and be treated and hopefully be discharged the same day. Our patients on the ambulatory unit come from GPs, A&E and clinic areas. The purpose of the AEC is to treat people on the same day and get people home. The purpose of EAUS is an admissions ward. So for those patients that come through our clinic and need a bed, they'll end up on our ward. And the patients that come from GPs and A&Es that are too poorly to walk into our clinic will be admitted straight to a bed on EAUS. My job mainly is to oversee all of the staff, to create the rota, check our staffing levels are okay, that we're compliant with our audits. I also investigate serious incidents, keep on top of incidents that happen on a daily basis, make sure that the ward is safe and we're working in a safe environment. But most importantly, my job is to ensure that we're providing a high standard of patient care. We have a really high turnover of patients. A lot of our patients are very poorly. The clinic leads on to the unit, so one can be very busy, one can be a bit quieter, but they feed off each other. We have to take into account the pressures of A&E. We try and take off them to reduce pressure on them. I did my training and finished in 2008 and qualified as a staff nurse at the Norfolk and Norwich Hospital. I worked on the unit and then I progressed to a Band 6, a deputy sister on the unit, and then I progressed into my post that I'm in now. Working through each band of nursing, going from a 5 to a 6 to a 7, is really, really interesting because your roles are very, very different, but ultimately your main aim is always the patient's experience.
My name's Luke Evans. I'm one of the emergency general surgeons. That's a general surgeon in the sense of somebody that deals with giblets, so guts, anything to do with the digestive organs. General surgeons in the past used to do lots more things. We've kind of narrowed down to really just dealing with gastrointestinal tract, so we don't tend to do things in the head and neck and the chest anymore. The emergency bit of emergency general surgery really relates to anything that's not a planned admission, so it's not necessarily rushing people to theatre quickly and doing lots of immediate life-saving problems, but the things like appendicitis or problems with gallbladders, problems with hernias, anything that might come in that's not a planned operation. Half my time is spent doing emergency work, half the time doing planned work. The emergency bit is really dealing with anything that comes through the door that fits within general surgery. In addition to that, all of us do at the moment, every 14 days we're on call from 8 o'clock in the morning until lunchtime the next day, and you can be called at any point in that, and about half of the time we're called overnight to come and either do some operating or to make some decisions about patients. There's a kind of misconception that surgeons, the only thing we do is operating. Probably that's about 20% of my job. About 80% of the time is actually talking with patients, trying to work out what's wrong with them, coordinating tests, investigations, coordinating their care and their social care and getting them well and home again. And actually, quite a small part of that is the actual technical operating bit. That's the bit we all like doing, but actually that's quite a small part of the life of general surgery. One thing that we often get asked about by medical students or school students wanting to sort of think about going to surgery is, oh, do you have to have steady hands, or is that a sort of barrier to progression? And bottom line is it's absolutely not. So some specialties require much more fine-tuned hand-eye coordination, but even then there's tricks and ways of getting around that if you have got shaky hands. So that's absolutely not a barrier to going into surgery. The barrier to going into surgery is really wanting to do it. One of the nice things nowadays is with the development of different technologies in surgical fields, and it's always been a fairly technologically advanced area, but we now have moved on from what people talk about keyhole surgery, what we call laparoscopic surgery, to robotic surgery, and those machines are becoming ever better and ever more sort of readily available for surgeons. So there is always some new development on the horizon that you can learn or be interested in. If you don't want the phone calls in the middle of the night from a doctor that's in the hospital and you're not there, you can't see what's going on, but you're still responsible for what's happening, then you need to think twice about going into that as a career. Things have changed a bit in terms of the hours culture, and people are much more demanding of a better work-life balance and being able to live their lives as they want, and we're very supportive of that. But there's no doubt there is an amount of long hours and a degree of sort of sacrifice about choices that you can make in your life to take that career. There's no such thing as going home at 5 o'clock, 6 o'clock, whatever, and forgetting about it. That patient that's had that operation is still your responsibility, and we work as a team, so people will pick things up for you, but ultimately they belong to you until they've forgotten about their operation and a long way out of hospital. So the commitment to that patient actually is quite long term. There's an element of overlooking that in thinking about sort of surgical careers compared to some other things. And the trope is always that the general practice is cradle to grave, and they know people over the longest sort of course of their lives, and obviously that's true. But as surgeons we do as well, and we see people for years afterwards. And certainly if somebody's had a complication, that lives with you and that patient for a very long time. There's sometimes a focus with surgery to think it's about doing something and getting that person well and recovered and home, and that's obviously what we want. And there are so many little elements to that getting that right does require lots of people to do their bit, and lots of people's expertise to make that happen.
I just really like that it's so varied, and there's so many different roles within anaesthetics that you can get into, and it's difficult to really appreciate that in medical school really until you start working, unless you happen to be exposed to that. But actually when you start working you realise that in anaesthetics you're involved in so many different departments, so many different things, so you never quite know what's going to happen in your day. I did my A-levels and then got an offer at University of Southampton, and then to go into anaesthetics it's 5 years at university, 2 years as a foundation trainee, and then anaesthetic training is split up into SHO and registrar level, usually 7 or 8 years, and then plus maybe more if you want to subspecialise. So I did a year at Great Ormond Street before I took up my consultant job here because I want to specialise in paediatric anaesthesia. So that's the path that you take to get into anaesthetics.
I qualified as a diagnostic radiographer and decided to stay in plain film because it's very varied. We go to theatres, we work in A&E, we work with inpatients, and we do a lot with outpatients as well. There's loads of different areas of radiography, so you can choose to go into CT, there's MRI, ultrasound, cath labs, interventional radiology. There's loads of different fields of then going into different specialisms.
I was a theatre nurse for 6 years, got this job, and then I went to university for a master's degree for surgical care practice. That was for 2 years. I think so because when you're a theatre nurse, you only just see a patient who's asleep on the table, and then after that you don't get to communicate with them anymore. So what this role has given me is to see a patient from the very beginning of their surgical pathway up to the end. So we see them before they come to theatre, during theatre or during the operation, and then we get to follow them up in clinic afterwards. So that's what I really enjoy most, is the interaction with the patient. You have a lot more responsibility, you know, the trust that you have to kind of inculcate with your colleagues and the patients. So you have to learn more about the medical side of things rather than just the nursing side of things. So being able to incorporate all of that, there is a bit more responsibility to be had.
Before I started my nurse training, I did a BTEC in health and social care, and then at the same time as doing that I was also a carer in a care home, which was a great experience for then getting into the UEA, which was the university that I did my nursing degree at, and then I came to nursing through that. At the start of the day, I get to work for about 6:45, 10 to 7, in time to get changed ready for our safety huddle, which is basically a handover for the main kind of safety aspects. So if anyone's at risk of falls or anything that we all as a team need to know. And then we break off into our own teams and have a more in-depth handover of our team of patients that we're going to look after. From then I tend to do a drug round, which is the first thing really that you do unless there's anything other emergencies going on or anything like that. From doing the drug round, we'll then have a catch up with all the doctors' ward rounds and see what the plans are for the patients. So that could be getting somebody ready for theatre, or doing someone's dressing, sending somebody home, and then it then goes on to lunchtime medications, and then in the afternoon that's can be a lot of transfers happen to other wards in the afternoons as well, because obviously we're the assessment unit, so we get people in from A&E, and then as quickly as possible we can get them to other wards so that we can make space for more patients from A&E. Sometimes when there is an emergency situation and your adrenaline is kind of boosting, that's one of the most exciting things, and then it's kind of just good to reflect on those kind of things afterwards.
So I worked as a support worker looking after adults with disabilities, and then I wanted to further my career really, and I was getting a bit older and I thought, what can I do instead? And I really like nursing, but it's quite funny because I've always been scared of hospitals, and then now I'm in one, my mum's always like, that's hilarious. But yeah, so then I decided to apply for the university, and really pleased I did. You do 50% theory and 50% practice. So you spend time at uni doing your modules and then you come on placement after. On some wards you have like a buddy who you can pair up with, and you like learn from other years. So sometimes they'll put a first year with a third year, so you can spend time and they know how you feel. So sometimes you feel a bit like you can ask silly questions and they'll answer them. And you get a supervisor who you're with most of the time.
My role involves collecting patients and the day-to-day runnings of the theatre. So we get called as a healthcare assistant on the wards, and then we've come into theatre as a theatre support worker, so there's no difference between it. So when we come in, we start the day at 7:30 like everybody else. We make sure the theatre is set up, we've got stock, we've got bits and bobs ready to go, especially even if it's just the first case, we've got the sets for there as well. We get involved in the team briefs to make sure we know about our patients as we go to send for them, and then we send for the patients. So we're the first, after like you've seen your anaesthetists and you've seen your surgeons, you see us as we're ready to come down to theatre. A lot of patients always kind of sit there and go, oh, we're going to go. And they kind of look at me like, yeah, we're going to go now. But yeah, we're working as a liaise, as it were. So it used to be that porters would come down and collect patients and the nurse would go with them. But we were created as more of a bridge gap so that the nurses can still stay on the wards and still do their job roles, and we were created so that we could go off, get the patients for them, set them up, and also be kind of a comfort for them as well. Skills are, for me, it was always just having a caring nature. That was always what you need, is you need to have an understanding. I've come from so I used to work on the wards. Before that I worked in a care home. Doesn't mean that you have to. We've had, one of my colleagues was a former tree surgeon before he joined our team, but he had a passion for it. As long as you have a passion, that's what, you can always come in from the healthcare assistant I did. I was brought in on a day to see if I liked it from a friend who works here. And I didn't faint, so that's always a good sign if you don't faint on the sign of blood. Coming into this environment is just, I'm very proud to work here.
A scrub nurse helps at the table at the operation, and she gets the sterile field ready and then helps the surgeon with anything he needs. Especially in emergency theatre, there's lots of times when we sit around and sort of wait for a patient, or one can come and they get changed for somebody who's more important or whatever. But then when things really happen, the whole team comes together. People come from everywhere to come and help, and it's just, you know, you can work with people and there'll be somebody have your back especially when you're scrubbed. Lots of people will help to get the whole thing going, and I love that. The clip of an instrument, when an instrument clips close, I love that sound.
My main role is within post-anaesthesia, so providing pain relief for patients and assessing them from an airway, breathing, circulation and a disability and exposure point of view. I cover adults, obstetrics and paediatrics, as well as external CT and MRI and brachytherapy. I began as a healthcare assistant on the wards, working on banks, so I predominantly went from medical to surgical wards. Realised that I liked surgical more, wanted to further a career, so later on in life I went back to college, studied my GCSEs, done an access course, and then eventually came to uni 2 years ago, so I'm now 1 year post-qualified. The excitement of surgery is quite amazing. It's quite an honour to look after patients post-operatively. There's a lot of things to think about. Every patient has a different story, a different reason to come in. They can be emergency, they can be trauma. It's almost very exciting. All the stuff, when I used to bank in accident emergency department, all the exciting stuff that came in there all came onto an emergency assessment unit, surgical, then they'd come in for surgery.
As a pharmacist in an acute care setting, you can expect your day to be really quite varied. No day is ever the same. It's busy and it's fast paced, but that allows us to really support the teams that we work with. Typically I'll start my day with a ward round and handovers with both the medical team and the nursing team to make sure that everyone is happy with what's going on, and if we have any problems or anything that anyone's worried about, it's highlighted early on in the day. Then it's my job to see as many patients as we have on the unit to make sure that we're using all of the medication for them safely and appropriately, and it's doing the right thing. It's 4 years of academic study with placements and things like that bring us into clinical environments, and then a year where you are doing the job. So for me it was a year here at the NNN as a pre-registration.
And when I started I did just look at it as a job, but since being here I love it. I really do enjoy this work. Our job mainly is to keep the ward clean and tidy, clutter-free at all times, to maintain all the trust equipment, i.e. blood machines, ECGs, report any faults with them and take them to the various departments, supporting the nurses when they ask you to, they might have run out of a piece of equipment they need from other wards, you run down and get them. You do the stock and the stock control within the ward to make sure that the ward is always fully stocked. I'm a people pleaser, and I like everybody to know that they can come to me for anything, but knowing that I'm doing something, no matter how small, that is enabling all the medical staff, the ward clerks, all the clinical staff to be able to do their job without stopping halfway through and thinking I haven't got anything or I need this. Just doing that, and it is a big thing, because someone could say, I haven't got a tourniquet, I need it straight away, and you're able to run straight away and get it and give it back to them. And I think that silly little things like that mean a lot.
Always something to do. The phones are always going. There's always patients, visitors, doctors coming up to the front desk, asking questions, wanting paperwork. I wish I'd have done this before I worked in the post office. I find it very interesting.
As an HCA, you are a patient advocate and their voice. You are solely responsible usually for their personal care, so washing, helping them wash, helping them dress, toileting, and also helping them feed if they can't feed themselves. You also do monitoring, observations, so blood pressure, temperature, respiratory rate, things like that, and feedback directly to your team, your staff nurse, the doctor, any findings. You're also mainly communication between yourself and the patient, because obviously you see them on a regular basis, you're face to face with them all the time, so you'll communicate back to your team whether there's any issues or worries, concerns about your patient. I enjoy being in a unique position to try and make a difference. I work in an emergency surgery department, so by that very nature, the patients are usually quite poorly, relatives are usually quite anxious. So for me to be able to be in front of these people and try and help them and help with the communication side of things and just ease the whole experience, that is my favourite part of my job, making a difference.
My mum and my nanny both work here, so I knew what it was like, and also Grandad was treated here, so I knew like the atmosphere was nice. I wanted to be one of those people who made people happy. I feel really inspired to do nursing, get into nursing, because I've been watching the nurses for the past year doing what they do, and I think it's just a very rewarding job to be in. I will hopefully be doing my HCA training soon to get into nursing. It's a 2-week course, and it's a lot of classroom and on site, and with Eastonmore they said they'd help me get there, and I'd shadow people here, and I think I know as well a lot because I watched everyone do what they do, and you know, I'm friends with a few of the HCAs now, and yeah, it's a 2-week course, and then after that it's just shadowing for a while after that, and then getting right into the role.
We use ultrasound and we produce diagnostic images looking at patients' anatomy. You get to sort of a dynamic real-time scan. You can also report on it. Most images that we take, whether it's CT or MRI or plain film, we don't actually give a sort of a diagnosis, whereas ultrasound, you work more autonomously and you sort of give a diagnostic report on that. Most people come into ultrasound after they've done a degree in radiography, so that will be their sort of basic honours degree, and then we kind of specialise in ultrasound.
With my job at the university, I work with the pre-reg nursing students, TNA students and nursing degree apprenticeship students as well, teaching them clinical skills that they need in practice. So I would say definitely get a grounding in healthcare first of all. So become maybe a carer of some sort to give you an understanding of what it's like actually on the shop floor, as they call it, rather than just sort of TV programmes or what you think you know. And then from there on, really, college courses. If you haven't got what they want, the accepted grades to get into uni, you can do an access course like I did. I had to go to college, sort of like a prep course for the university. You get to make a difference in somebody's life when they're probably having a really bad time, so that's quite a nice thing on a human level to do. But also, the roles are unbelievably varied and wide, and the numbers is massive. You will never be bored, and the sky is the limit pretty much. You can do what you want to do, to be honest with you. Yeah, make the job work for you as well, yeah, definitely.
We cover many different sort of areas in physiotherapy, but mainly it's when patients come in following illness or an injury, once they've been seen by the doctors and the nurses. Once there's sort of a plan, physios tend to come in, get people back on their feet. If it's an orthopaedic injury, try and get them home, and if they can't get home, whatever's the best area for them, try and get them basically back to previous level of mobility and function. It makes you feel really great, actually. Yeah, I mean, we see some patients with spinal cord injuries that have come from a major trauma, and this is obviously a life-altering situation, and to see some of them make the progress that they do, you spend a lot of time with them, and it makes you feel really good, and that actually all the hard work getting to that point to become a physio is definitely all worth it.
My final years of university involved a lot of work on the hospital wards, which meant that I was getting into the role of becoming a junior doctor, so that when I then made that transition it was a little bit easier for me. So we were doing a lot of ward round based things with consultants where we were able to get a lot of teaching, as well as alongside that getting lectures while in university, so that then the clinical stuff we were learning we could back up the knowledge that we'd learned throughout, as well as talking to a lot of patients and just getting comfortable in that kind of role. When we're learning practical procedures like taking bloods, it's all very well doing it on models, but there's no way that that can kind of imitate properly how to do that on a patient when they say they're in pain and things like that. It changes the dynamics of the interaction a lot. So being able to do that with lots of different types of patients really kind of makes you more comfortable in the role and happy to do those procedures when it's then your real job. My general working day at the moment involves coming in, I get a list of patients which I need to see for the day. I then usually go around with a registrar or consultant, so a senior colleague, and they make plans for each patient that we see on the ward round, and it's then my job to enforce those plans and make sure everything's in place to allow the treatment to continue that we've decided on. With regards to how busy my day is, very much depends on how sick the patients are day to day. So some days everything will be quite straightforward and you can just get on with the day-to-day tasks that involved, unfortunately, a lot of paperwork. On other days, some people will get very sick and they will take up all your time and you will not stop all day. And that just very much depends day to day on who you're looking after. No doctor could do anything without all of the nurses. Like the HCAs do all of the care for the patients, wash them, dress them, all of that side of things. The nurses give all the medications that we prescribe. And being able to get advice from those people about how they feel about the patients is really important as well, because they spend a lot of time with them, whereas we might not be able to. So being able to work in that team and get a lot of support from everyone is my favourite thing about the job. All the way through my school career, I was kind of volunteering or doing work experience in relevant areas so that it would go towards my application, and all of my GCSEs, A-levels were all kind of lined up in order to then be able to apply for medical school.
So I started at Norwich Community Hospital as an apprentice healthcare assistant. So that was a year long, and that was just sort of getting the insight of what a role of a HCA is. So that was just sort of shadowing people, taking observations, just sort of all patient care. It was an adult rehabilitation. It started with personal background. I sort of helped look after my nan, and then from there I just thought that by helping her, I just thought that I wouldn't really want to do anything else. I really like caring for people, so I couldn't see myself doing anything else. I have got a uni place next year. I just think that by starting here, there's so many opportunities, so many training that you can do, and I just think that I want to push myself to become a nurse in the future.
So the role of the clinical educator is to support new staff on the unit. So it's newly qualified nurses who have just finished their training, new HCAs who maybe have never been an HCA before, and staff who are just new to the unit and the specialities. It's also working with students, so people that are doing their nursing training at the time. A lot of my role is reassuring people that you don't have to know everything. You've got a long career ahead of you and you will learn and gain experience as it goes, and that from the very beginning you've got other people around, you've got a team around you. A lot of what we do is talking to people, getting information from them and using that to help a doctor to diagnose the problem. A lot of nursing, I think, is about common sense. So there is a lot of theory that we do have to learn, but a lot of it, putting it into place, is actually about being organised and logical and having that common sense that something's wrong and that you need to get help and escalate it. With EAUS, because we only look at emergency patients, so they are patients that have been going about their day-to-day life when something's occurred and brought them into hospital. So they're not expecting to come into hospital. On most wards you'll have some emergency and some electives, so people that expect to be there. And because we are the team that first see the patients, we are the ones that sort of assess them, assess their health. So some patients are actually quite well, but then we'll get some patients that are incredibly sick. And we see such a range of injuries, and how we treat each patient's different depending on what they've come in with. Every day is different.
I'm responsible for the leadership of the nursing and nursing teams within the wards and outpatient areas and associated specialist nurses. I enjoy being a leader of some fabulous teams and seeing them grow and develop. I think it's really important to see people grow in their careers. We've got a lot of junior people that I've helped to shape to their futures where they are now in senior leadership roles. I feel that nursing is a fabulous career. I feel very privileged to be a nurse and to be able to support patients in the way that I've been able to throughout my career. Patients come to us very vulnerable and they want safety and security, and it's our role to make them feel safe and secure in our environment that they're completely unfamiliar with, and it is a brilliant career for anybody wanting to join.